you are missing out on a fantastic venue here today. I see a lot of families out there enjoying things, which is another great part of this course every year. So Gil and Niru got us off to a fantastic start this morning, but I think we're going to equal it with our next group on lower GI. And our first speaker really needs no introduction, but of course I'll give him one. He is the John Stroline Distinguished Professor at UT MD Anderson in Houston. He's done many, many things in his life, but the most remarkable thing is his dedication to teaching. And I got to tell you that he is the first speaker that I've ever read a bio of that leaves us with a quote from an Indian saint. So this is from Sai Baba: "Hands that serve are holier than lips that pray." And I think that tells you something about Gottumukkala Raju, who is our speaker. He goes by Raju, so for questions, Raju only. Raju, please join us.
Good morning. Thank you, Garrett. Thank you, Eric. Thanks to the Society for this great honor. And what I would like to do is, unlike the previous session, I thought that I'll share some of the tips and tricks of how to remove polyps. And Dr. Riker is going to cover the latest advances in this area. So my talk will be more like a primer. So these are my acknowledgements. So when you look at a polyp, you have to ask two basic questions. Is this a lesion good for endoscopic mucosal resection? And when it comes to that, we should go back to the anatomy of the colon wall. As you can see, there are four compartments in the colon wall: the mucosal compartment, submucosal compartment, muscular compartment, and the serosal compartment. I want to use the term compartment because as long as the pathology is limited to the mucosal compartment and you remove it, whether you remove it en bloc, piecemeal, as long as you remove it completely, you can achieve eradication and you can avoid recurrence. So that's something to keep in mind. When the lesion penetrates the muscularis mucosa and it goes into the submucosa, then depending upon how deep it goes, there is increased risk of lymph node invasion. So when we look at it, adenoma with or without high-grade dysplasia or intramucosal cancer can be taken care by EMR. When it goes into the submucosa, if you can remove it en bloc, you can do an EMR. And if you think you cannot remove it en bloc, you should consider endoscopic submucosal dissection. When the lesion goes further down, then you should be thinking about surgery because the risk of lymph node invasion increases. One thing that has developed in the recent years is full thickness resection for relatively superficial lesions into the submucosa. And I'm glad that Dr. Riker is going to cover a lot about these concepts, about which lesions we should do EMR, which lesions can be taken care by FTRD, and why we should avoid surgery for lesions limited to the mucosa. The next is the extent of the cut in a horizontal fashion. So one is depth and the second one is the extension. When you look at a lesion, what is obvious may not be just that lesion. There might be something going beyond the confines of what is totally obvious to you. That, if you include in your resection, you could avoid recurrence. And that subtle lesion surrounding the obvious lesion is defined as the skirt lesion. So when you see a lesion, don't jump and try to cut it without spending time to figure out how far it extends beyond. It may be just very, very subtle. So something to keep in mind. I would like to share 3 examples of where you can achieve curative resection with endoscopic mucosal resection. One thing is, if the lesion doesn't have cancer, doesn't really matter, you can get rid of it with endoscopic mucosal resection. You do not have to do ESD. But problem is, some lesions may not have the features on the surface to indicate cancer. That's where we go wrong. So here is a large lesion, and we were able to resect. And this patient I followed for almost 10 years with no recurrence. Another patient, I removed it about in 2012. Actually, I scoped him just last week. I can't even find the scar. And another lesion. So I'm giving these examples to let you know that you can actually eradicate lesions without worrying about too much of recurrence if you follow simple principles that I would like to share with you. So when I started my practice at MD Anderson Cancer Center, I set up a protocol in 2009, and I followed the protocol religiously. Even last week, I just followed the same protocol without changing. When it comes to the protocol, there are a few things that I'm going to discuss as we go through this protocol. So this is what the pathway that I go through. One, if a patient is seen by a referring endoscopist, what that endoscopist should do to help the referral center to take care of that patient better. So when you see a lesion, we always try to describe the size, the morphology, the location, but something that is always missing in the report is, was it difficult to reach that site? And that is going to help the referral center plan their procedure. If it is technically difficult to reach the site, if you don't mention that, the guy who's going to take care of the patient may be thinking that, hey, this is a small lesion, I can do it in 1 hour, but it may take 2 or 3 hours because it was technically difficult to reach that site. Something to keep in mind. The next one is, when you want to document the lesion and put a tattoo, make sure you put a tattoo distally in the same plane as the polyp, at least a few centimeters distal to the lesion, and not into the lesion. If you inject into the lesion, it will create scarring, and that will limit the ability to lift and resect. So do not put a tattoo into the lesion. Do not put a tattoo into a cecal lesion. It's not uncommon that we continue to see that. The other thing is, we are all busy, and when we send a referral, sometimes they come as black and white, and the guy cannot even figure out what to do. It's best to have the color pictures so that they can look at it and come up with a plan. In my practice, I do not have open access for EMR. I always see the patient and talk to the patient. It's important to share with the patient not only the complications, but with EMR, unlike ESD, there is a need for follow-up at 6 months and 18 months, depending upon the type of the lesion that we are going to resect. And if they miss that, they may get into trouble later on. And finally, when it comes to the endoscopy unit, it's important to discuss the plan with the entire team so that they know that they have all the accessories available in the room. They shouldn't be running to find accessories, because then you get into trouble. You may want to control the bleed and you don't have an accessory. So that is really very important. Unlike others, what I do is I always do my EMRs under general anesthesia. That gives me a stable field so that I can resect properly. It is also important to put a cap, and when you put a cap, the side hole should be away from your suction channel, so that when, depending upon where the lesion is, the side hole will drain the fluid so that you can have a clear view. I don't know how many fellows are here. If there are fellows, I want to share one thing. As you're learning colonoscopies, it is not about reaching the cecum fast, but reaching the cecum with the shortest scope, 60 to 70 centimeters. If you practice that, you will be able to do EMR. If you go with a long looping scope, you will not have tip control to be able to resect safely. So the most important thing in EMR, first step, is to reach the cecum with a short straight scope so that you can dance around the lesion to cut the polyp. So now coming to the assessment of the lesion, we have several different things. First is this cancer or not? Is there a skirt lesion or not? And it's also important to figure out, is the lesion dependent or not? How do you find out that? You flush and you find out if the lesion is dependent or not. If the lesion is dependent and you try to cut, and if it bleeds, you will not be able to find the bleeding source. The pool of blood submerges the small vessel and you will struggle to find the bleeding vessel. Instead, you rotate the patient so that you make the lesion non-dependent, and if it bleeds, you can find a spurting vessel to one single spot and you can actually achieve hemostasis very quickly. So these are small principles, but every small principle makes a difference in how you get the job done nicely. So when it comes to the EMR steps, in terms of the solution, I just use saline. I don't use any of the ready-made solutions because saline gives you a softer cushion so that your snare doesn't slip. With the viscous solutions, what I've found is the snare tends to slip. And if you use saline and you cannot cut, it is not going to create a lot of submucosal fibrosis that develops with some of the other solutions that can happen, because that makes it very difficult for the next guy to cut. And when I use saline with indigo, I want to see that I can see the markings on the backside of the syringe if I look up. So that's the sky blue color you want to get. In terms of injection, as you get into the submucosa, you want to inject in such a way and direct your needle so that you bring the lesion to a position that makes your resection much more easier. And let us look at it. So we have these 4 compartments. You want to get into the submucosa and you give a small amount of aliquot of fluid. And once you know that it is in the submucosa, then you change the direction of the needle as your assistant is injecting. So there are 3 principles for a submucosal saline injection. 1, you have the biopsy port, you have your catheter. I hold it 1 finger breadth away from the biopsy port. That's the amount of distance I hold my catheter, and that's the small movement I do to get into the submucosa. This is true especially in the cecum, when the cecal wall can be just 2 or 3 millimeters when it's distended. So that's a small movement. And once I know that the needle is below the epithelium, I ask my assistant to do a tap-tap. That means This will give a small aliquot of fluid, not too much of fluid, and then it will lift your mucosa up. And once you know the mucosa is lifted, then I try to move my scope tip and direct my needle the way I want as the assistant is injecting. And I ask my assistant to share with me how much amount is being delivered, 1 ml, 2 ml, 3 ml, because otherwise you may be injecting 10 ml into the peritoneal cavity without even realizing. So sometimes when you are not sure and somebody has done a biopsy of a polyp and then you did not recognize the scar and you try to get into the submucosa, you may end up in the mucosa and create a mucosal bleb. You must have seen that. Don't pull the needle back. Instead, make a deeper puncture into the submucosa and use the same spot to get into the submucosa to get a lift. The next one is, you may be injecting and your needle has gone transmurally and you're not getting the lift that you want to see. In that case, again, don't pull it back. Just gently withdraw till you find the submucosa and then deliver the injection. So I want to show you, this is how I do the injection. The lesion is still a little bit dependent. So I'm making a puncture. And once I make the puncture, I ask my assistant to tap, tap. So you can see small amount of bleb with each tap. And once I know that it is in the submucosa, then I ask my assistant to inject a little bit faster. In terms of the snare selection, I try to use a stiff snare, typically 10 millimeters when I'm working in the cecum, maybe 15 millimeters for lesions outside. One important thing that I want to mention here is we are delivering current to cut, and you need to see what is being delivered. So to achieve that, make sure that your electrosurgery unit is in front of you and your assistant tells you what settings are being delivered. If you don't do that, you may be delivering a current somebody has set and probably not the current for that patient. In terms of the snare application, you start your resection from the normal looking area, and then as you cut, in EMR, you want to learn how the wall is looking, and you keep your snare parallel to the wall underneath the first cut, and you keep moving. Keeping it parallel to the wall is critical to avoid the risk of perforation. The principle to avoiding a perforation is a good submucosal injection, and you're keeping your snare parallel to the wall. And as you cut, you should be able to see the depth of your cut. If you see a nice meshy submucosa, you're cut in the upper 1/3 of your submucosal compartment. And submucosa is the strongest layer, and this will prevent any risk of perforation or delayed perforation as long as you keep your submucosa intact. The next one is, in the last 10 years, we have learned that snare tip soft coagulation of the edge reduces the risk of recurrence, and this is something we should all be using. In my own practice, for the last 15 years, I've used only APC, and with APC, the recurrence rate is also very low, around 3 to 4%. The advantage of APC that I find is sometimes the snare tip is not easy to control, but with an APC, you can still deliver a very good ablation. Finally, after resection, especially in the right colon, you want to close the defect with clips to cut down the risk of delayed bleeding. And when it comes to marking the site, what I do is I have my catheter filled with saline, and then I ask my assistant to take the tattoo, the carbon particle injection material, and flush the catheter till it comes and stops just before it enters into the scope, so that the catheter inside my scope has still saline. I create a saline bleb first, and then I continue the injection, which will fill the saline bleb with the tattoo. So that if your injection doesn't go in, you are not likely to mess up the whole lumen. So I try to do this so that you have a clean tattoo placement. You should be prepared for controlling bleeding. And with bleeding, you could control it with your snare tip, soft coagulation, 80 watts, effect 4, and it controls almost 90% of the bleeds. So one thing that I've changed is in the electrosurgery setting that I use Irby machine. On the left side is my cut, on the right side is usually forced coagulation. So when I'm doing EMR, I change my forced coagulation setting to soft coagulation up front so that I don't have to change my settings. By having my soft coagulation, I'm already ready with my setting. I'm not changing in the middle of the procedure. All I have to do is ask the assistant to open up the snare tip and then use the blue pedal to deliver the current and take care of the bleed. If a bleeding is brisk from a bigger vessel, then you may need the grasper that can deliver the current. Sometimes you may not be able to see the bleeding and you're groping. Don't use current. In that case, probably best is to use your clip. It's a mechanical device. You're not going to cause more thermal injury, and you can control the bleeding by grasping a lot of tissue. We know from a lot of studies that are published in the last 5 years that clip application, right side lesions have been shown to be beneficial in cutting the delayed bleeding. Coming to perforation management, I want to share one thing. When you think about different layers of the colon, submucosa is the strongest layer. As long as you preserve the submucosa, you are not going to get into trouble with delayed post-polypectomy syndrome or delayed perforation. So when you inject indigo carmine and you cut, I want to show you a series of pictures that will tell you the depth of your cut. So here is superficial submucosa, then deep submucosa, and you can see muscle, but no damage to the muscle. When there is damage to the muscle, this patient is going to come back with delayed post-polypectomy syndrome or perforation. This needs to be prophylactically closed with a clip. And obviously a muscle injury, a little more depth, and then a perforation. Nowadays, based on all the work that has been done in the last 20 years, we should be able to manage these perforations with clip closure. And when it comes to clip closure, most important thing is when you close, you should not leave any gap in between the two blades of the clip, because that type of clip closure, as you can see in the picture, will secure your closure and unlikely to get loosened. So how do we go about doing that? I want to show you the principle of clip closure. So you can see the clip, and when the assistant closes, every clip that is available in the market will retract by a few millimeters. If you do not compensate for that retraction, what happens is you will deploy the clip a little bit superficially. So as you can see, as a clip close, it retracted by a few millimeters. You have to compensate by either moving the scope forwards or pushing the clip forwards, with your assistant closing the clip slowly to allow you to make that movement to achieve a deep closure. And that deep closure will secure your closure. So once you've done the job, when the patient comes back into the recovery, most of these patients should not have any symptoms. And it's important to make sure to follow up, because the problems are likely to happen in the first 2 days. And then important to make sure that there is a surveillance program at 6 months and 18 months. So I'm going to talk about risk of incomplete resection with EMR. It's very interesting, even at DDW recently, I'm a little bit disappointed to see that we are still reporting high recurrence rates for EMR. And we should have a recurrence rate of under 5%. And that is achievable if you follow the principles. So there are so many different things that are being published in terms of how to cut down the recurrence. What I feel is, once you cut, if you get into the habit of taking pictures of your margin every few millimeters, that will automatically make you focus and look at the margin carefully. That would cut down your recurrence. And the second one is, although I cannot prove it, I do all my procedures under general anesthesia. Sometimes the patient is paralyzed, so that I have a stable operating field. That is probably helping me to have a good resection, examine the margin well, and able to cut down the recurrence rates. So that is something important to keep in mind. So when it comes to follow-up, how often should we follow? Traditionally, we have followed for 6 months and 18 months. And Michael Burke and his group have shown that if you have a low-risk case, you can push it to 18 months. Not necessarily everybody requires 6 months. So when it comes to recurrence, there are several techniques people have described, but I feel that heart biopsy avulsion takes care of majority of the recurrences. And what you do is you set your electrosurgery setting to endocut eye, and you hold the polyp, put a little bit of tension, and then press on the yellow pedal that will nicely dissect that polyp and create and avulse the polyp and able to get rid of the polyp tissue. After this type of avulsion, if I know that I can clip close the defect, I go and burn that area additionally with APC. If there are cells there, I'm going to get rid of them. For those of you who are interested in EMR, especially for the sake of fellows, I put a lot of videos. These are about 340 EMR videos that tells you how to resect different types of polyps without editing. I just put it whatever happens on the screen, and then several for tethered polyps. I would like to take a few minutes. To me, our outcomes depend not just on endoscopists but on the team, and I would like to share with you something about developing your endoscopy crew, because we don't have a program so far. For 7 years, we worked on this program to create an endoscopy technician training program, and I'm pleased to share with you that the Houston Community College is able to graduate some people. My aspirational goal is to figure out and come up with an associate degree in endoscopy technology for technicians, with the hope that they can actually become BSNs in endoscopy technology. We have reached up to level 2 now. The next is go through the next steps. And I would like to thank the Houston Community College who worked with me. And these are the graduates for the last 3 years. And the program that we developed for the community college is also available at the ASGE. And ASG has started an associate membership for technicians. And if any one of you want your technicians to go and learn, the material is available there. And thank you for your time. Really appreciate it.